Hey everybody, I'm going to do maternal code education for this year's virtual skills fair to get ready for our maternal survey. The reasons why a mom would code: venous thromboembolism. We know that pregnant and postpartum women are in a hypercoagulable state due to the physiology of pregnancy. Preeclampsia or eclampsia, both being only known to the pregnant and postpartum woman. Maternal sepsis. Amniotic fluid embolism, which, contrary to popular belief, has nothing to do with an emboli. It's actually a sensitive reaction between fetal proteins and maternal blood. Hemorrhage, whether that be intranatal from an abruption or if that's postnatal due to uterine atony with a postpartum hemorrhage. And DIC, of course, our moms are at risk for that. Traumas, any med-air allergies, of course, anesthesia, and hypermagnesemia. We use magnesium infusion for neuroprotection for the fetus in preterm labor, as well as medication to reduce the seizure threshold in those patients who are preeclamptic or to treat an eclamptic seizure. In addition to this, there's pre-existing heart diseases, congenital or acquired. So the number one cause for maternal code is due to maternal cardiac disease, which previously was not so much realized, but in the last years where it's really been hitting the news that lots of American moms are dying, we're realizing that the pregnant population is not just a healthy population. They have just the same comorbidities as any other group, young or old. Precipitating factors to a maternal code: chronic kidney disease. Again, we don't always have healthy moms. They do have these type of comorbidities. Neuro disorders, lung diseases, specifically asthma. A lot of women who are asthmatic refuse their medications during pregnancy to reduce any harm to the infant. And obesity. We have, especially in the East Texas region, a large population of maternal obesity, which feeds into that triad with thromboembolism and cardiac disease. Physiological adaptations of the pregnant woman. So of course we have a uterus that's rapidly growing. After the 12th week of gestation, the fetus actually doubles in size, getting up to sometimes 7, 8, 9, 10, and we even had an 11-pounder this year. So with that, of course, the guts are shifted up, the diaphragm shifted up, everything's stretched out, and it makes it a little bit more difficult for that mom to not only breathe, but just for her organs to function. So intubations are 7 times more likely to be failed in these mothers due to the shifts. Gastric contents have a lower pH, which means when they're aspirated, or if they're aspirated, there's a higher risk of morbidity and mortality. Of course, you see the pregnant woman waddling across the parking lot and she can't breathe. That's because her diaphragm is very displaced. So it's difficult for her to breathe on a regular day, much less when you put stress on her body. And due to these adaptations, effective CPR is impeded and the cardiac output is severely decreased, which is why left uterine displacement will be essential, and we'll talk about that. So speaking of a maternal code, what does ACLS on a pregnant girl look like? The exact same, despite the fact that she has a belly. It's the same meds, same algorithms as a non-pregnant person. You can still defib these patients and cardiovert. There's expected to be minimal energy passed to the fetus. You shouldn't defer rapid defib just because the fetal monitors are on mom. However, if you can get them off, get them off. The lateral pad may have to rest under the breast tissue due to those maternal changes. So whenever a mom codes, you need 2 code teams for the mom and for the baby, because if mom's going to code, if the baby is born, will be coding as well. So you need a team and a team leader for the adult resuscitation, or the top half of mom. You need a team leader and a resuscitation team for the bottom half of mom doing OB care. and a team leader for neonatal care and a resuscitation team for when that baby comes out. One thing that I really want to drive home with this presentation is, and it talks about it on the next slide, is the fact that many times if we have a mother code, we're going to do a perimortem cesarean section and we need to get that baby out. So just like any other ACLS patient, epinephrine is preferred. And then once ROSC is achieved and the mom is stabilized, you can reinitiate electronic fetal monitoring, because really it shouldn't be on during resuscitation. It won't be effective. This is an algorithm or a chart just kind of showing what is different about a maternal cardiac arrest. Again, it says ACLS is the same, however, it includes the manual left uterine displacement, detaching fetal monitors, and preparing for a C-section. This is huge. So the neonatal team needs to be there at any maternal code if possible, because if no ROSC is achieved by 4 minutes, you should perform immediate cesarean delivery. This is left uterine displacement. There's a one-handed technique and a two-handed technique. This is basically getting that heavy gravid uterus off of the main source of blood flow to mother. If that is being impeded, then the CPR is not going to be, I believe it's 30% less effective, because the blood's not able to flow as a person who does not have a heavy gravid uterus. So the big topic of perimortem cesarean delivery. This is birth of a fetus after a maternal cardiac arrest, most commonly during resuscitation. So that means while somebody's pumping on mom's chest, somebody's at the bottom cutting their baby out at the same time. So this is not only benefit to the infant, but it also facilitates maternal resuscitation, just like we spoke of. If you get that heavy gravid uterus off, your CPR becomes more effective. So the optimal place to do this C-section is at the site of arrest. CPR quality decreases on the way to the OR. So this is something I really, really, really want to drive home, and that I'm excited to simulate in our upcoming code sims, is that if this mom codes an L&D or on antepartum, we will cut her baby out in the L&D suite or in the antepartum room. We won't transfer her to the OR. Likewise, if this mom comes into the ED, or if this mom arrests in the Walmart parking lot and comes in by EMS, we will do her C-section in the ED. As soon as she hits the floor, we will be down there to do that perimortem cesarean delivery in the ED while somebody is resuscitating her. So without adequate cerebral perfusion, of course, irreversible brain damage occurs within 4 to 6 minutes. Neonatal survival and an intact neonatal neurological status is likely if delivery occurs within 15 minutes of arrest. The highest incidence of intact neurological survival for neonates has been reported if delivery occurs in less than 5 minutes. And this is why we drive home that we will cut this baby out as soon as possible, especially if it's an unwitnessed or an out-of-hospital arrest. We are going to have a perimortem cesarean delivery kit that we currently have in labor and delivery, also duplicated to be available in the ED if this situation hopefully never occurs, but if it does, to be prepared. And we plan to use that in our code simulation. So, of course, in situations where mom is not resuscitable from severe trauma, we need to deliver the fetus. Again, this will be a perimortem C-section delivery wherever we can get mom to. If the gravid uterus is large enough to cause hemodynamic changes in the mom, and it's going to be a life-saving measure, ultimately we should do the C-section regardless of the viability of the fetus, unfortunately. We talked about unwitnessed arrest. So as far as sterile procedure, that goes out the window. We're not going to be in the OR. However, if there's a bottle of betadine or chlorhexidine lying around and handy, which should be in the perimortem cesarean delivery kit, that can be dumped on maternal abdomen. It doesn't have to be scrubbed up. It just needs to be dumped. And all you really need is the scalpel. After the C-section, oxytocin should be used in caution. Normally, this is something that we bolus and run for 4 hours, but it can precipitate rearrest, and so we want to be cautious with that, and then continue the left uterine displacement even after the perimortem cesarean delivery until we can get that mom stabilized, because even though the infant's out, the uterus is still heavier and larger and filled with more blood than a non-gravid uterus. So for L&D and antepartum, our crash cart does have a guided maternal code timesheet. However, if this was not on the second floor, any recording sheet should be good for a code because it's the same procedure. Immediately post-arrest, place the mom in full left lateral position or maintain the left uterine displacement. As I said, the patient should go to ICU unless further operation is required. And then, of course, like in any other code, we want to consider our H's and T's so that we can treat that mom accordingly. If you have any questions, please feel free to reach out to me by email or by phone. Thanks. Have a great day, y'all.